therapeutic value may be there in certain high risk or unfavorable
It has
group.
been for last
Maybe.
20 years the same question marks.
रीजनेबल हुआ, ऐसे भी लिफ्ट हो रहा है और ट्यूमर, हाँ ये यूरेटर है, ठीक है ना. सुबह सीखना शुरू हो गया. ये क्या है? इसलिए इसको ऊपर ले ले. फिर कोई वैसा लग रही है छोटी सी एक्स्ट्रा. वेसल्स है, छोटी मोटी वेसल्स है. हमें ज़रूरत है उतना ही सोचे ना. हाँ हमें जो ज़रूरत. हाँ ऊपर दिखा दोस्त. वो एंगल ले जा, अंदर ले जा दोस्त, अंदर ले जा. हाँ
Right, can you go with the case history, please? Unmute yourself and go with the case history.
1 minute, na? The sir varanga.
Give me the PowerPoint, please.
Oh, this is that. All right, okay.
Could somebody please present the case?
Okay, he's had a...
Can we proceed with the case history?
Yeah, please go ahead.
Please go ahead. This is a 56-year-old male. History of hematuria is 3 months. Only positive findings here is in the history that he's a laparoscopic cholecystectomy for 10 years at a private hospital. So that's the right side, and he's getting a radical nephrectomy done on the right side also.
Next slide, please. Baba, can you give us?
Looks normal.
Which is quite normal. Next slide,
Next
please.
slide, please.
Right, it's a large mass. Fair enough.
Next slide, please. Next, please. Yes, one more, please. Next.
Large.
Next. Yeah, go on.
Is there any CT angio with this?
Okay, can we go live to Dr. Shrenik, please? Audio to Dr. Shrenik, please.
Good morning, everyone.
Hi.
Yeah, am I audible? And can you see the image?
Shrenik, you are very much audible and we can see the image also.
Okay, fine. If I begin with, we have put 5 ports I'll just brief you. I normally try to put one extra port for colon, which I can retract, and one port for the from the above, which we can probably uplift the kidney above the psoas. That is what is normally our goal is. Here we do expect it's a large mass, so there could be many more vessels will be there. So our goal will be, once we do the colon mobilization, we'll try to go for the hilum.
Okay, but before you start, actually,
It's
just
the
let us
right
know.
side. Have you done an angiogram on this? Or do you normally do an angiogram?
No, I think there must be CT angio only would have been done, probably. See here
I
you
think
are
we are
able
not
to
seeing the
see.
picture. If you have got that CT angio picture, can you please let us know how many vessels do you have?
Yeah, these all
Yes,
are
this is
extra
a
vessels
CT
what you are
angio
seeing,
patient.
yeah. So what
And
we have
what-
started doing is, yeah, I'll make it dry, yes.
And what camera system you are using, my dear?
This is a Wellneck system. This is a 4K and it is a local made. That is what I was told. Yeah.
And
Look.
how do you rate this vision as compared to what we have been conventionally using?
Look, this is a, I think, can you see the psoas? We have started lifting it up. Yes. This is a psoas. So we have first mobilized the colon. And this is what you can see the psoas very well. It's a large mass, definitely. So we have to be prepared. Our goal will be to, these all are extra vessels. So you will like to go for the hilum first. And this is the left side. So I think the side also makes a difference, that we should know that what kind of, here it's extra vessels. Come here. Just, yeah, retract this. See the colon, you will see we have gone right up to the upper pole. Just show upper pole. This is what we have already mobilized. Can you appreciate? This is, I think, the kidney. Yeah, for the upper pole, we have done dissection till here. And again, coming back, this is if we start from the lower pole, this is the mid and the lower pole mass. So now we are going for the hilum. And as there are extra vessels, so we will go, yeah, these are all the vessels. This is one of the vessels.
Shrenik, for the benefit of all of us, can you please give us a panoramic view of entire mass and the kidney?
Sure,
so that
sure.
we can appreciate it better. Okay.
Okay. Yeah, can you see that? See, this is
Yes.
a lower pole, this is a whole mass, and this is a colon which has been mobilized. All right.
Dr. Shrenik, could we just give it a wash because it's a little down the darker side?
Sure. We'll do that.
Yeah, please. Thank you.
भाई लगाया हुआ है saline? Wash देना है तो.
Shrenik,
हाँ?
this is Dr. Raina here.
Yeah.
I mean, would you ever in these cases which are large masses, stuck masses, mobilize the upper, then the lower, then posterior, and then lift them together, and then you'll see your hilum very clearly. Would that be a sort of which you would like to do sometimes?
See, I am sorry, but unfortunately I couldn't hear. So, Anand, can you make the voice little?
No, that's fine. Can you hear me now?
Yeah, it is better. Yeah.
All right. Sorry, it's my voice actually, it's not Anand's fault. You know, when we have these very large masses, and I do them robotically and not laparoscopically, then we go to the upper pole. It's anyway, we're doing a radical nephrectomy. Then the lower pole, we mobilize both the poles first, posterior, then lift the kidney up, and then we start going on the hilum. I see you've gone on the hilum right away. Is there any advantage of that? Just a suggestion.
No, I agree. See, what you are telling has a sense. If there is any emergency, if we have upper and lower, that is what exactly we used to do in the open surgery. That if we have to probably enter and we want to have a hilar control, so that would be useful. I take your point, and that is why we did a little dissection of the lower pole, the upper pole also I dissected bit. Then I thought these are the extra vessels, we are aware. So we will probably now go ahead after watching individually each one.
Fair enough. Yeah.
अंदर ले जा.
How many ports do you have?
Five ports.
Right, right, fair enough.
Yeah, we'll clear it off, right.
Yes. See, that's what I said. When we do robotically, I must admit, we try to get the vessels as far away as possible. But, I mean, because now he's gone posterior, you can see the swaths clearly.
This seems to be a better
Yes,
plane
yes.
coming from down along
Yes,
the aorta
yes.
rather than going way towards the hilum.
Once you go in the hilum, there's a problem. You don't have control from below and above, then there's a problem. Are you using the harmonic quite frequently?
So this is actually Sony season, they call it. So either of the, see, this is our choice. The only advantage of this is a wireless. So
Right.
as the mobile and all technology is getting changed, they have also come out with, last time also when we demonstrated, so this has been little useful. You can see we can individually go to the vessels and take care of.
Absolutely. Yes, it's very nice. Yeah. How many assistants do you have with you right now?
3 people.
3. Yeah. Okay. Have you ventured into the era of robotics, or as you're such a good laparoscopic surgeon, you don't think that's necessary?
Sir, I believe upper tract surgery, especially the donor nephrectomy, then simple nephrectomy, and I believe majority of radical nephrectomy can be very well done. Even if I would have available robot, I'll prefer to do by laparoscopic.
Fair
Yes,
enough.
if it is a partial or if it is a prostate, I don't think everyone is self-robot like Malli. What is he demonstrated the laparoscopic surgery, lap radical prostate so well. So suturing does make a difference. So I think for partial and prostate, yeah, I definitely believe. it
So
is better
basically
to-
what you're saying is when there's reconstruction, you prefer a robot. and
Yeah,
when there's
yeah,
ablation-
precisely.
When there's
Very, very,
ablation,
very,
you
very
would
good.
prefer
Yeah.
a laparoscopy. Fair enough. Sounds fair. People like us who've been brought up only with robotics, we have a little. How much suction do you normally use in laparoscopy? Do you try to cut the suction as less as possible?
Well, suction I use more for the dissection rather than only doing a suction.
Right.
So just to make a good planes also I think to dissect it out, you want to enter somewhere behind the artery, vein, if you want to figure it out. And it keeps filled clean, obviously, if it is required. So the dual purpose, yeah. Brother, andar aa jao. Yeah, you come here. Wait.
What about your ports in this case? Are those these long ports? Like we have these long robotic ports, or your ports are the standard ports?
No, these are the regular ports only. These are the regular ports.
Handing the mic over to Mike.
Because see, the dissection and the whatever we are going to see, hilum should be in front only. So and patient is fortunately not that obese. Otherwise, you are right. If we would have been suspecting, then we would have definitely be prepared for that. See, this is what I like to dissect behind the things before I cut, and then I go and then I cut that area.
Dr. Shrenik, they are about to start. Dr. Anup Kumar Gupta is about to start.
Please.
the site.
Yeah,
We
go
will
ahead.
get a case history from them, sir.
Sure.
Babu, can you mute Dr. Shrenik and give us the case history, please? If there's no one, go ahead. You keep changing slides. That is okay. Next slide. Slowly. Go back.
அண்ணா 1 மினிட்னா இங்கிருந்து சார் வரும்.
So there was a 40-year-old male with hematuria since 3 months.
Increase his mic, please.
He has undergone ERCP with CBD stenting 9 months back, a lap cholecystectomy and a transurethral resection of bladder tumor in April. Next, please. It's fairly normal investigations. Next, please. There is a 54 cross 20 mm lesion in the right lateral wall of bladder. Next, please. CT suggestive of the same. arising from the right anterior and lateral wall of apex with bilateral VUJ involvement, leading to mild hydronephrosis and hydroureter on both sides. Anteriorly, focal area of infiltration on right anterolateral aspect of caudal part of urinary bladder. Perivesical fat stranding. Okay. Next
slide.
A fairly large mass.
Next slide, please.
So appears T3A.
Next slide, please.
Any comment on the lymph node?
Next slide, please.
TURBT specimen suggestive of invasion into the musculi. So, yeah.
Next slide, please.
T3B.
Yeah, next slide, and we can go live to Dr. Anup. Dr. Anup? Babu, could you unmute Dr. Anup, please?
Yes, na? Is mic on, na?
Dr. Anup? Good morning, Dr. Anup. Can you hear us? Babu, audio program parunga. Our mic varla. Hello, Dr. Anup. 1 minute, I'll tell them to increase the volume inside. 1 second, sir. Can you hear us better now?
Anna, voice.
We can hear you. Can you hear us clearly? Okay, fine. So please tell us your game plan. And you are using a 3D system, right? Yeah, so which 3D system you are using? Okay, Dr. Anup, we'll just change the microphone to you. We'll just go to Dr. Shrenik in the meantime.
तो ये नीचे वाला हटा दे ऐसे दूर. Yes, lift करो.
Yeah, Shrenik, we are with you.
Yeah, I believe, can you see the vein we have dissected?
Yes, very clearly.
Yeah, and then I
The
think...
vein is nicely seen. The vein is nicely seen.
Here behind this, I expect the artery to be there. थोड़ा नजदीक रखो.
Can we go back to Dr. Anup for a minute? Dr. Anup? Yeah, much better. Your audio is much better.
Anup, can you orient us where exactly you are? Right.
How long back was the TURBT done, Anup? 19th April. It's quite recently, actually. Yeah, all right. That's why there's a lot of inflammation. 1 month, yeah. That's okay.
Actually, sir, from the slides on the history, we were not able to really make out the lymph nodes. I mean, on the CT report. So, sir, can you tell us about the lymph node status?
Right. What was, I'm sorry, I didn't get the histology, Anup. Was it high grade? What was it? Muscle invading high grade?
High grade squamous metaplasia.
Oh, squamous metaplasia. All right. Has he been given new adjuvant chemotherapy at all? Yeah. All right. Very bad response, actually. Yeah. And what happens with this new adjuvant chemotherapy is when you're going to operate, most of these tissues are not the best tissues. You know, they look like cheese. So, unless it's not very high grade, though it's muscle invading, I'm not very sure I like to do this new adjuvant chemotherapy. I like to first do the cystectomy, see the results, and then accordingly decide. Of course, if it's very high grade, you have no choice. Yeah, clearly seen. Do you normally send frozen sections of the ureter? Okay, what if you have a single ureter, like you have a nephroureterectomy done, bladder gone, now you only have one ureter? Would you send frozen sections there at least? Right. Absolutely. Okay, fair enough. Now, why I'm saying this, because I have a chap whom I did a bladder tumor resection. It was non-muscle invading, but high grade and large tumor. Came back later with 6 cycles of BCG, etc., 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 and now it's a muscle invasive. That left side kidney is not working. So he goes in for nephroureterectomy and then he goes in for cystectomy and then he has one ureter to go on an ileal conduit. So would you do it that time? Is what I'm asking.
Why it is so much adherent?
Because 4 weeks has already been passed since the thing.
That's a puberty.
Yeah, so I would take a frozen section on this ureter.
Anup, there seems to be a lot of adhesions. There seems to be a lot of adhesions. The ureter normally it can be dissected easily. Here you are. So what could be the reason? What would be the reason for this?
Absolutely, yeah. You can see it very clearly. There is a lot of periuretritis, tremendous amount of periuretritis. But you said he has been given new adjuvant, right? He has not been given new adjuvant. Okay. That's a good thing, that's a good thing, that's a good thing actually.
Shrenik, do you have any comments? Can you go to Dr. Shrenik by the time he dissects the ureter? Anand? Can we go connect to Shrenik?
Shrenik sir?
Yes.
Can we go to? Yeah, so Shrenik, any comments? We are watching you.
Yeah, I hope you can see the anatomy. We are trying to figure out, this is renal vein, this is lumbar, and we are trying to go and figure out the artery, but we know that there could be multiple veins, extra veins, so we are going little slowly as
Because it's a large tumor and you're obviously keeping all the gerodas intact, which is lovely.
Yes, yes, yeah.
But mercifully is the left side Shrenik.
Pardon?
I said mercifully is the left side. So you'll have a significant amount of a large vein.
Yeah.
So once you does the lumbar and you lift that vein up, you'll find the artery nice and proper there.
Right, absolutely. It's a necklace. Unless we take care of lumbar, it is impossible to get the artery. I completely agree. I thought I'll dissect around the lumbar first. I'll try to make it free, and then I think we'll take care of a lumbar. Yes, absolutely true.
Sir, do you think that coming more medially towards aorta will help you more?
Pardon?
Coming more medially towards aorta will help you more to find the artery faster?
Yeah. You mean over here, na? This is the area.
Yeah.
Very true. But I thought if we will take care of this connection, which are more tiny and can unnecessarily bleed the lumbar, and then actually you are right, we are going to find out here only. This is a transverse aorta from where we will figure out so I think I would prefer to first take care of lumbar and then figure out the artery rather than doing it before.
Because if the lumbar slips, it's a bit of a problem. This is like our donor nephrectomies.
Yeah, I agree. So ideally, as you rightly said, here we can go ahead without taking care of this if we can figure out the artery. But then I have to go up, and this is a hilar area where there are extra lot of vasculature is there. So I thought it is better to go to the normal
You're absolutely
area.
right. It is better to dig the artery towards the aorta so that you got a decent length to
Exactly.
put,
Look, this is now
to
I
put the
can
clips also.
now probably find out the depth and the total width of the lumbar.
Because the wheelock takes a good amount of space. When we put wheelocks, it takes a good amount of space, and you prefer to put two nice wheelocks in something like this. And most of these large renal tumors have a lot of neovascularization. And I think you're doing the right thing by just clipping slowly, slowly, slowly.
Sister, can you give me the right angle, please?
So would you be open to using hook here to have a final dissection?
Hook. I used to do, or we have done when we did not had a harmonic. The first 500 all surgeries we did by using hook only. But of late, I think we are not using it unless it is must. See here, I am just trying to see okay, what is the depth. I am not just penetrating. I am only trying to figure out because this lumbar can have a different shapes. They can be some at times octopus. They may have a different. So we don't want to penetrate. I am sure the same care we take during the donor, we take here. And we need to be very sure. And we want to find out a common limb, and then I would come out, and then probably I can figure out this is a lumbar. I hope it has been shown a little bit because of big mass. I am not able to lift very well.
It's very clearly seen, Shrenik. It's extremely clearly seen.
Okay, yeah. Can you please? तेरा अंदर चला हाँ दो clip 5 yeah clip ना 10 mm ની આપણ વેન મોટી છે this is a large vein
It's very nice. That's what we call it scissors.
always see the tip of it before applying it. That is what I would recommend it those who are, yeah, if I can see the tip, then only I should apply. Yeah. Now you can probably better appreciate. Yeah. Can you give me one more, please? थोड़ा दिखा, center में रखा.
Shrenik sir, Utsav here. Sir, do you always use hemologs even for lumbar?
If it depends on the size. If it is a large, like in donor, we have started using 5 mm clips. But if it is a large, then I think it is better that we use a 10 mm. No. Yeah, that's reason.
Can we go to Dr. Anup sir's OT?
Anup sir?
Would you like to send this ureterus margin for frozen? And in a dilated ureter like this, would it be better to use a suture rather than using multiple clips? Can we switch over to the other OT, Dr. Anup? We'll be right back with you. Can somebody switch it
Shrenik
to?
sir?
Yeah.
So we are with you. Tell us how you are dealing with the lumbar.
Yeah, I think, see, as I said, lumbar shape is always different. Even though we were feeling that we have covered whole, but it looks like there is a small lip, another which is left out. Look, this is, I can see the open vein itself. So
Yeah.
now we'll like to little dissect it out better. And then we'll apply a clip. Like this is a now complete thing. We could now separate it out. So again, look, this is been left out.
Yes.
Yeah. Sister, give me a clip, please. Can you see that? That's an open
Yes. The
vein.
stretched vein
Yeah, that's
part
open
of
vein,
it.
yes.
Yeah.
So I think it is good to learn that if it is any problem, always see the things, dissect it out.
Mr. Chairman, are you permitted?
Give me one more.
I want to direct some questions for the bladder case. From the histology, we have been told it's...
Hi, yes, please.
Yeah. From the histology for the bladder case I'm talking,
Yeah.
it was squamous differentiation. It is not squamous cell carcinoma, it's squamous differentiation.
You're right.
So if I heard you correctly, you were saying that chemo, neoadjuvant chemo has got no role. Actually, that was true for squamous.
Yeah.
Squamous differentiation, actually, it has got a definite role. The only difference is that these patients...
I think we are connected to Shrenik, so just hold on for a minute. Anand, if you can connect us to Anup.
Anup sir?
Okay, Anup, there is a question for you, so you please listen to the question and then answer. Please, can you please go ahead?
Anup, I was referring to the histological report. It says squamous differentiation. It's not pure squamous cell carcinoma. Am I right? Yeah, so in these patients, actually, there is a good role for neoadjuvant. See, as it is, these are very aggressive malignancies, usually presented at one stage, like you pointed out, and their 5-year PFS is less than conventional transitional cell. So, in fact, you need multimodality. This is not a curative surgery. Neoadjuvant is required in these patients. Yeah, it is. There's not much data on what you're saying. The other thing I would like to ask you, when you have an aggressive T3 disease, what is your plan? Would you go for conduit, or would you also look at the possibility of doing a neobladder? Not in this workshop, but otherwise in your setup.
So any difference in opinion? Uttam, did you hear the question? Did you hear the question? Okay. So, or maybe Amit, if you can answer what has been told by Dr. Anup. Yes, please.
Yes, I'll rephrase the question. The question was, it's a squamous cell differentiation. So is it same as a squamous cell carcinoma of bladder? In other words, in squamous cell differentiation, does the neoadjuvant chemotherapy, does it have a role or not? And Dr. Anup said it may not work as well, but I feel that literature-wise, it has equal role as a TCC bladder. And there's also no suggestion that it may be aggressive than a TCC bladder. Yes. So maybe we can have an opinion from the hall, what everyone's practice and they feel about this particular question. Differentiated, de-differentiation into a squamous cell versus TCC having some amount of squamous differentiation. What do you feel outcome-wise, or what is the practice? Would you actually give a neoadjuvant or not? So what is the opinion of the hall? Maybe raise of hands would tell. Yeah,
So, I think you can take a poll, na?
You know,
Yeah.
this is a high grade. If it's common differentiation, it's a high grade.
Yeah.
And if it's a high grade, then I think you require neoadjuvant.
So see, I think one point is very clear. Any patient having squamous differentiation need to be treated like a uterine carcinoma only. There is no doubt about it. So the plan of management will be same as you treat any uterine carcinoma. So now the problem is that there are certain, we think of the level of differentiation in that. You see reports having 20% differentiation, you see some reports having 80% differentiation. So there are a lot of studies that are coming up about the level of differentiation, whether they can be 20 or not. But as of now, consensus is they need to be treated like carcinoma as we treat a normal carcinoma. Immunogen indicated, it need to be indicated.
And sir, I agree that the new adjuvant is indicated, whether it is normal differentiation or not. As far as possible, it has no specific contraindication. If it is a cisplatin, the patient who can tolerate cisplatin-based chemotherapy, for an invasive carcinoma of bladder, it is better to start with new adjuvant, followed with cystectomy. Of course, there can be specific situations like deterioration of the renal system, hydronephrosis, but the approach for the squamous differentiation in a TCC remains.
So I think everyone will agree that squamous cell carcinoma of the bladder versus UC with squamous differentiation. There's two different things. UC with squamous differentiation should be treated as UC only, what Dr. Ankur had told.
So most of the people the experts in the audience believe that we should cover with the neoadjuvant, right? And to stretch it further, would you like to go for a allele conduct in a given case or a neobladder?
The type of diversion will not depend on these sort of factors. The type of diversion will depend on so many other factors that includes the renal functions, what the patient wants. And because this is feasible to do, go ahead with the quality of life will be definitely better. But majority of the cases, what we are doing nowadays, or maybe many of us are doing either lap cystectomy and all those things, their diversion is usually ileal conduit. But there's no contraindication for doing an orthotopic diversion.
Sir, I think while we were talking about these differentiations, we tend to group all of these as variant histologies, but there are actually two distinct terms. One is variant differentiation and the other one is divergent differentiation. So variant differentiation is actually a different origin of that cancer. It is associated with very specific molecular changes. And divergent differentiation is what a urothelial carcinoma would undergo and turn into, urothelial carcinoma with squamous differentiation. So when you have a divergent differentiation, you of course give neoadjuvant chemotherapy to that person. But when you have a variant differentiation, you do not. Now, the reason I'm talking about all of this is because in recent years, there's a lot of emphasis being placed on the molecular classification of bladder cancers, whereby they have grouped it into baseloid types, epithelioid types, and all of these variants are grouped into high risk, low risk. So a urothelial carcinoma with squamous differentiation actually is one of the lower risk types, whereas a pure squamous cell carcinoma is a higher risk type. So if you have a urothelial carcinoma with squamous differentiation, you give neoadjuvant, and if you have a pure squamous, you do a surgery straight away. This is actually the point of distinction.
Can I ask the panel a question? A rather stupid question in an elite audience like this. 10 centimeter, 15 centimeter renal tumors with such collateral, neovascularization. Do you think open surgery is dead and gone?
Open surgery is not dead and gone. Open surgeons are still doing a great work of radical nephrectomy. But if you're a good laparoscopic surgeon or a good robotic surgeon, I promise you the patient would prefer this today rather than a very big cut. Having said that, in a large tumor...
My question is 1 minute. My question is there. So, just by doing a laparoscopy, you will be able to take out that 15 centimeter tumor through a small hole?
No.
Then?
But you'll put it in a bag and you'll be able to get that bag out with a lesser cut, which will be a trans-abdominal cut.
I don't totally agree, but well, for the grace of this conference, we'll agree with you.
That's what I have felt in my own practice.
I will disagree with Dr. Ghosh because the thing, even if
you can't disagree, Uttam. 1 hour ago, you were advocating poor India. And now you're advocating bikini surgery.
I was just talking the same thing when you had asked that question. Yeah, how we are going to take out these things? I said when we started the laparoscopy, we used to give the incision in the subcostal place, but subsequently we are now giving incision in the iliac
Chairman,
fossa.
my only big submission is this, and that is when you are doing either laparoscopically or robotically, your dissection your dissection pain is much less. In the post-operative period, your pain is definitely lesser. Your post-operative recovery is definitely faster.
And the place of the incision is also very different, right?
Once you will stop talking, we will talk. The question is, it all depends on the surgeon how best he can convince the patient to take the particular surgery. That is so simple. These patients with this type of tumor, if I can convince, which I have been able to convince because I don't do laparoscopy, and they get it done by me, and not much of a problem post-operatively.
There is a great problem post-operatively.
What do you mean?
I promise you that.
There
Listen
is
to
a
me.
big scar
I'm
here
talking
also.
about myself. When I was doing open surgery and when I'm doing robotic surgery, my patients are far more happier, sir. I can assure you that.
You are
Just
right.
listen to
You
me.
are right. No, as you are sitting as a chairman, please listen.
No, sir, I'm talking about
I
my
have the
experience.
boys with me who do very good laparoscopic surgery. They have been doing with me. They are sitting there. If I am not doing laparoscopic, don't think my unit has not been doing.
I am not saying
But
that.
the question, they do wonderful. They do laparoscopic transplantation also. But the question is, it is a matter you have to give the choices to patient. You say, this is this, and if the patient said, no, open kijiye.
So my nephrologist let's agree on open, would not agree on laparoscopic donor nephrectomy.
I think this let me intervene. Sorry, Gautam. I think both of you are right, sir. If somebody is in a position to convince the patient as well as his efficiency, if somebody can do a very good job with open surgery, still it has a place. Somebody who is actually very good into the laparoscopy or a robotic surgery, and if he can convince the patient, probably that is also a good option. So both the options are correct. I think the only thing that changes is the place of the incision. Generally for a larger tumor, we maybe putting a flank incision, and that may cause some kind of pain post-operatively. And or transabdominal, sir.
So now, I think the other way around, if we ask the question, when you will say no to laparoscopic radical nephrectomy. So no to laparoscopic nephrectomy, there are few areas like huge mass, one thing, and second thing is there's a huge lymph node in the hilar dissection. So huge hilar lymph nodes, we cannot go for it. Otherwise you can go for a laparoscopy for 10-15 centimeter. It is easily doable. It can be done. So rather than asking why should I do or not, why should I not do it? That should be the question.
So can we shoot this question to Shrenik, the very same, then let us see what he tells. Okay? Shrenik, are you with us?
Yeah.
Shrenik, are you with us?
Yes.
Okay, so there is a debate going on. Such a large tumor with lot of neovascularity.
Right.
Would you like to still go for a laparoscopy or
Yes.
a robotic surgeon?
Yes.
Let's just hold on. Or open surgery is equally a good option if surgeon is very good and is in a position to convince the patient for the open surgery. What is your answer?
Right. I still believe laparoscopy is good. I do agree. The incision what we will be putting will be only the width of the tumor, not the length of the tumor. That is one. That is to remove. But colon mobilization, overall I think even we have done 15-18 centimeter masses, the incision will be smaller. Yes, there would be an incision. We don't deny there would be incision, but it would be much smaller. It would be at a different place where we are putting. Biji clip up,
But such a large tumor, you said 18 centimeter tumor,
right?
Such a large tumor with lot of neovascularity. Do you think that your operating time also may be more?
I know. It may be 1 hour more. See, this what exactly we are putting is seems to be artery. But one of the artery, we are not sure whether it is a main artery, but we are taking it for granted that we need to take out and take care of every vessels what we are thinking are coming on the way.
Sir, I just want to add a few things from the perspective of people like me who have just started their surgical careers in India. So the decision between doing a laparoscopic cystectomy or an open cystectomy or a robotic cystectomy, it doesn't depend on the patient and doesn't depend on the advantages only. Sir, I was doing high volume laparoscopy, then I did high volume robotic surgery. Now I'm in a center where I'm doing open surgeries. And the reason is not because I cannot do laparoscopic surgery or the patient doesn't have an advantage. It's because I do not have an assistant who can show me 30 up. right? I maybe, if I do an open surgery, I take out the bladder in 4 hours, 5 hours. Patient has very less time under anesthesia. He will recover and he will go home. So open surgery, it should not depend on just how expert you are with laparoscopy or robotics. It should also depend on what is available to you at that point of time. If I work in a big cancer hospital which doesn't have a robot yet, and I do not have a skilled assistant who can show me the way Anup sir is being shown the camera. So why should I break my back? Why should I toil for 6 hours, 7 hours? Whatever the patient will, lose by having a bigger incision, he will gain by having a very short anesthesia time. So if I can finish it in 5 hours by surgery,
then we give it to you.
yes, absolutely. I will definitely do open surgery. I am doing open surgery.
Absolutely.
Yes,
You are basically going to treat the patient the best that you can. My only argument under this is that you are perfectly justified. So is Dr. Ajay Kumar.
ये और एक नंबर है.
But
ये इसने पकड़ा हुआ है देख.
sometimes when we go in for the robotics or laparoscopic,
है ना? ये कर देंगे ना ऐसा.
good help.
फिर वो
Surgical
दिखेगा.
time may
Right
be a
angle
bit
up
more, but his post-op recovery is far better.
लग रहा है बराबर है?
The only thing is that his post-op recovery, and I've seen it in my own patients.
But I'll just add one thing. The robot should be it should be used judiciously. For a radical nephrectomy, one should not go for a robot. That is a wastage of robot.
This is between laparoscopy and robotic. But what I'm saying I'm not just saying robotic.
So I think two areas where robot should exclusively be used, that is the partial nephrectomy as well as radical
I
prostatectomy.
maintain that robot is for
Otherwise, for
reconstruction.
radical nephrectomy, we should not use a robot.
I maintain robot is for reconstruction and laparoscopy is for
और वो लगेगा अच्छा फिर वो नहीं लगेगा ऐसा नहीं होगा.
I'm only saying between open
5 में कभी-कभी फिर नहीं लगे यार अपना.
Uttam, you said correctly, but I think probably this is
क्योंकि इसलिए मैं कह रहा हूँ.
practice now. Those who have robo, they will always say that robo is better, and they will sell it to the patient. So maybe in future, not today, maybe in 5 years down the line, I think many of us who are sitting here will start doing robotic surgery even for the radical nephrectomy for the renal tumors. So the time shall come. I mean, right now you are very right deciding, but maybe after 5 years it will change. I think
we can't oversell the robot, that is for sure. It's like our renal transplant unit. Initially it is
okay, I think let's go to the so let's go to the
Anup. Dr. Anup, sir, tell us how difficult it is for you to do it. Yeah.
That's the bladder.
Yes.
Anup, can I give you a feedback? This is Amit here. In this AUA, there was a presentation by Tom Parles, practically the #1 man in bladder cancer, who is basically trying to find out some urinary and blood biomarkers as to who will benefit most out of neoadjuvant chemotherapy in T3 bladder tumors. After he lectured and gave us his GAN on what are the latest modalities of biomarkers for 5 minutes, then he asked for a raise of hands. There were about 1,000 people in the room, and he said, let me ask you a question. And the question was, how many of you, there are a cross-section of people across the world, how many of you in a T3 case actually use neoadjuvant? And there were only 10 hands. And the reason, one minute, Tom Pauls concluded that there are 3 issues that he wanted to point out. Number 1 is if you do give neoadjuvant, that has got its own morbidity. Number 2, it has got a financial toxicity. And number 3, most of all, it melts the tumor and the patient is confused as to whether he should at all go in for a cystectomy at all or not. Number 4 was, you have wasted so much time, at least 6 months' time. So, in conclusion, you have lost and you have actually deprived the patient of his best chance of survival. That is a very interesting discussion that we had.
No, but you're absolutely right. You're absolutely right. Very often we see it looks, it's like it looks like cheese. Very cheesy when you're doing the cystectomy after giving neoadjuvant. And this patient is very vulnerable. But having said that, would you operate a very high-grade bladder tumor with nodes without giving a neoadjuvant chemotherapy?
No. On principle, no, but in practice, yes.
Right. Thank you.
Actually, if you go through the history of neoadjuvant chemotherapy for bladder cancer, the people used to wait for the turn of surgery. So when they are waiting for the turn of surgery, then people thought, why not to give this chemotherapy and see what happens? And that's how they found that there is 8% benefit, 7 or 8% benefit at the end of 5 years survival benefit. Small benefit with that cost of toxicity, what has been told. So in our centers also, see, in private practice, majority of the people will do a TURBT and then send it because nobody wants to do a radical cystectomy in a private, because there are limitations. So in PGI, every 3rd beds are occupied by radical cystectomy patients and they are waiting. When the patients are waiting, maybe the patients will be psychologically benefited also. And definitely there is a benefit. RCT shows a 7-8% benefit of this thing. But what you are telling is true. The post-operative mortality is really, really high. But it can be done. So, personally, I don't go for a T2 disease. For T3 onwards, one should go for it.
Thank you. Can I extend this discussion by one?
Please.
Okay, so my question is, if you do practice neoadjuvant in T3, what is the recommendation? Do you do 3 cycles and then an imaging? Yeah. Or do you do 4 cycles right off and then image it just before you take him out?
I do 3 cycles then an imaging.
Because here again, we are skewered in our practice. Many of us, we image after the 2nd cycle. If there's a good response, we proceed to the 3rd. If we find nothing, we label it as non-responsive and go ahead for a cystectomy. So your comments, please.
Anup, can you give a comment on this? No.
He's concentrating on surgery, so rather than this theoretical discussion.
Anup, the comment is, if you are giving neoadjuvant, how many cycles do you give and then test? Yeah.
So actually, now again, the question is what sort of regimen you want to give, whether you want to go for DD-MVAC versus GC. DD-MVAC, the concept came that the same question what Dr. Ghosh was telling, if you are go for a neoadjuvant chemotherapy, you will be waiting for a longer time. But if you go for a DD-MVAC, that means in a short period of time, you can administer maximum dose of chemotherapy. So patients should not wait more than total waitage period will be about 50 to 51 days, not more than that. So that is not a big wait. Now, rather than asking, say, how many cycles you will give, it doesn't respond. What we are facing nowadays, suppose patient has responded completely. So you have given chemotherapy and nothing is there, neither radiologically nor cystoscopically, nothing is there. It's very difficult to convince the patient that you still need cystectomy. So what should be done? What is your opinion? Complete response.
This is exactly what Tom Pauls said. He was the researcher, the primary researcher. He was the one who was interested in chemotherapy. But he found out, to his utter surprise, that the patient compliance was getting lower, and he had missed the biggest chance of recommending an operation and quasi-cure the patient. That was the point of issue. That the patient becomes difficult to convince after 3 cycles of chemotherapy, after 6 months have gone, and radiologically you don't find anything.
So answer is as of today that one should go ahead with cystectomy because we don't have any evidence if you don't go ahead with the cystectomy whether in the long run there will be any survival advantage or not.
Yes.
I don't know where. Who is talking? Okay. So can I go to the other theatre, please?
Can we go to
the... Sir also ask some...
Dr. Shrenik, sir's OT, please.
Shrenik, sir.
Dr. Shrenik, please.
Shrenik, sir.
Yes. Hello.
Sir, do you think that the clips in the lymphatics are obscuring your view to reach the artery?
I agree. See, we were expecting there would be a lot of veins, but now I think we could dissect the artery out.
Yeah.
And the only disadvantage of this multiple veins is you may come across the veins, the clips may come in between, but that's fine. That is what we were expecting. Fortunately, we could now dissect out the complete artery well. I am just trying to go behind it.
Dr. Shrenik, can I say something?
Please, please.
So what I would have done, I would have dissected behind these vessels.
Right.
So you create the space between the kidney and the psoas. Once you go there, from behind you can see the artery better. So you can avoid all this. You have a big lymph node, which I can see, and all those lymphatics. So if you come from behind, most probably would have been better off to do this thing.
I tell you, we did try that. But this is because of this extra veins and this we were not able to see it. Otherwise in donor what you're saying is very true. We go behind the artery and we go into that lifting up the lower pole. Here the another problem was the mass was so large that we could not actually lift up the kidney also well. We were little worried that we don't want to penetrate or we don't want to open up the mass. Now I think you can probably appreciate the artery well.
Very nicely done. Very nicely done.
So I would like to thank the chairpersons. We'll go on to the next session.
Very nicely done.
Thank you so much, sir, for the...
Yeah, thank you so much.
Very good, Shrenik. I hope you're still enjoying your surgery.
The surgeries will continue in the background. We will start with the talks ahead. I would like to invite the chairpersons for the next session. Dr. Premnath Dogra, Dr. Ganesh Kamath, Dr. Gopi Chand, Dr. Vineet Ajitsaria, Dr. Umesh Sharma, and Dr. Harish Thumar. For the first talk, talking on non-muscle invasive bladder cancer surgical treatment, I would like to invite Dr. Ravichandran K. and Dr. Srivatsanar.
Can I have the slides, please? Good afternoon, everyone. Welcome to session 4 on conundrums of urothelial cancer. And the first topic for this session is surgical management of non-muscle invasive bladder cancer. Well, this is the table showing the probabilities of disease progression at 1, 5, and 10 years for a EAU NMIBC risk group. We all know there are 4 risk groups. And if you just look at the 5th year probability of progression, for the low risk, it's 0.93%. And for the very high risk, it's 40%. It's a phenomenal number. 40% is the probability of progression. And how do we risk stratify NMIBC? These are the factors. Except for the first 2 factors of age and tumor status, rest all the factors are determined based on the cystoscopy you do and based on the TURBT and the histopathology results you get out of it. So this is the importance of the way we diagnose and manage the NMIBC. The whole risk stratification weighs on your procedure. Coming to the second slide, I want all of you, especially the residents, to ponder how is the outcome of T1 high-grade bladder cancer versus that of a T3B prostate cancer, where you know both seminal vesicles are involved, it's a locally advanced prostate cancer. I just want you guys to ponder, like, what is the better outcome between these 2 groups? And we will come to it at the end of the talk. Well, this is the brief overview of my talk. First, we'll be just briefly touching on the diagnostic cystoscopy, followed by basic tenets of TURBT, and multiple techniques of doing TURBT, what are the complications, how do we try preventing, and few of these special situations. Coming to diagnostic cystoscopy plus histology is the gold standard. We all use either flexible cystoscopy or rigid cystoscopy for the diagnosis. And there is this paper published in 2017. They've compared flexible versus rigid to see which of the two is better tolerated by patients. No guesses, flexible is superior to rigid. When we are doing a flexible cystoscopy, when we reach close to membranous urethra is where the patient will kind of resist, and that's where the pain is little maximum. So one technique what residents can do is squeeze the irrigation bag, increase the irrigation flow so that the membranous urethra will open up, the resistance will come down, so you'll be able to better tolerate. And there is also a randomized trial supporting this evidence. Well, what are the details that we should know at the end of the TURBT? We have to know what are the total number of tumors, what is the size. How do we measure size while doing a TURBT? The size of your loop we use is around 1 centimeter, so that can be used as a marker. How does the tumor look? If there is any calcifications, what is the location of the tumor? What is the T-staging that you think, whether it looks like a muscle invasive or not? And what is the characteristics? Is it a sessile, nodular, papillary, a solid flat tumor? And if there are presence of CIS or not? Whether you think whether the detrusor is present in the specimen or not? And probably before and after resection, you can do a bimanual palpation. Probably the role of this has come down with advances and easy availability of imaging. And whether you have achieved a complete resection or not. And if you encountered any complications. Please remember all these points. Next, once that you have done a resection, how do you know that you have done a good job? Many a times a complex TURBT for residents, especially either your senior will walk in or a consultant will walk in and say that you may not be able to manage it, the results may not be that great and let me take over. So residents, pay attention for this slide. There is this study where they have looked at the association of surgical experience with that of a detrusor presence and how well these group adhering to the standardized checklist, the 9 points which we just dealt in the previous slide. To our surprise, the detrusor in TURBT, when the residents are following this 9-item checklist, residents done better than compared to consultants. And the checklist completion rate was also better with residents as compared to the experts. So the higher adherence to checklist was associated with higher presence of detrusor, and surgical experience was not associated with 5 years recurrence-free survival. So as long as you're sticking to the checklist, you are sticking to the basic tenets of TURBT, irrespective of the surgical experience, certainly you can do better. Contrary to that paper, there are umpty number of other papers supporting that surgical experience is better, but still, data says as long as you're sticking to the basics, you should be fair enough. Next, coming to techniques of doing TURBT, it can be either a piecemeal or a separate resection, en bloc, or multiple ways of doing the procedure. Coming to piecemeal or separate resection, this study published in BJUI in 2012 looked at the role of extended TURBT. What do they mean? Once you're done with the procedure, they would again take another bite from the deep muscle and the periphery of the resected site. And what does the study say? The extent of the residual tumor was close to 38% in these additionally taken specimens. So at the end of your procedure, if any doubt, either use a cold cup or a loop, take an extra bit of deep muscle, and rather than just running your cautery ball through the periphery of the lesion, if you can resect a little more and then achieve coagulation, probably it will go a long way. Next, coming to en bloc, enough has been discussed and debated in multiple forums saying that en bloc is superior to conventional resection. I think the summary of this paper should be good enough. This meta-analysis has looked at 29 studies evaluating close to 4,500 patients. The risk ratio for bladder perforation and the differential rate for detrusor muscle presence was in favor of en bloc. The en bloc resection had a lower rate of residual tumor at repeat transurethral resection. Hold on for a minute. But then the pooled risk of 12 and 24-month recurrence risk ratios were not statistically different. So as long as whichever technique you are doing, you stick to the basics and do it well, I think you should be good enough. This was another paper, an RCT, published in 2023 in European Uro-Oncology, wherein they have looked at retrieval of detrusor muscle, which was superior with en bloc, bladder perforation was better with en bloc, obturator reflex was less with en bloc compared to conventional, operating time did not make much difference. In second look TURBT, borderline conventional was better, but when you looked at the recurrence at a median follow-up of 13 months, en bloc was slightly higher. So though look-wise it would look better, that en bloc you're doing a good job, but then at the end of the day, the recurrence ratio seems to be the same. So while improving on the quality indicators for NMIBC, the long-term differential oncology benefits of en bloc TURBT remains uncertain at this point of time. Next, coming to debate between monopolar versus bipolar, we have multiple studies. There is no definite significant advantage in efficacy and safety with bipolar. Though bipolar minimizes intra-op and post-operative bleeding with smaller loss of hemoglobin and shorter hospitalization time, and less obturator nerve contraction and less tissue artifacts. Apart from that, no real benefit per se. Coming to few difficult situations like tumor at a dome, probably you can give a suprapubic pressure and bend the loop, tangential to the wall with minimal bladder filling. This suprapubic pressure has to be given by you, not your assistant or the superior. You have to give your suprapubic pressure and manage accordingly. Tumors in anterior wall, again, suprapubic pressure would do. Diverticular tumors, since there are no muscle, be really careful with the depth of your resection. And if you think it's a high-grade tumor, better to consider for cystectomy. And if there is a tumor near ureteric orifice, rather than being over into and aggressive and using your cautery ball to burn that whole area, use a pure cutting current as minimal as possible, because there is certainly a risk of ureteral stricture of 4%. And is there a role for DJ stunting? This paper has addressed it. It's a systematic review and meta-analysis. They have looked at stunting versus PCN versus no drainage. And the conclusion was stunting as a preventive measure should be avoided as much as possible as it increases the risk of metachronous UTUC. Next, coming to the role of prostatic ureteral biopsies. How many of us routinely take prostatic ureteral biopsies, and where are the instances that we have to take? Any T1 high grade with an incidence of CIS in prostatic urethra is around 11.7%. Any positive cytology without evidence of tumor in bladder, take a ureteral biopsy. Suspicion of CIS, bladder neck or trigonal tumors, any abnormality in prostatic urethra, and if you are planning for neobladder in subsequent stages, take a prostatic ureteral biopsy, rule out malignancy so that there won't be any recurrence. And where do we take it? Between 5 and 7 o'clock position near the veru using a loop. Next, coming to the role of random bladder biopsies. If there's a positive cytology and normal bladder, take multiple random biopsies. Any abnormal looking mucosa, take biopsies at multiple sites. And use of narrowband imaging and photodynamic diagnosis is available, which my colleague Dr. Srivatsa will be dealing shortly. And when you are doing a TURBT, if at all you come across a small tumor in the bladder, what do? The dilemma here is that you resect, is there a risk of seedling? You resect and can you give an immediate intravesical instillation? So there are these two papers, two meta-analysis. The summary is, any papillary small unifocal tumors you can resect along with TURBT with no increased risk of recurrence or progression. If you are in doubt, rather than giving a single intravesical mitomycin where you fear patient may develop some complication, rather you can give a saline irrigation. That should not be a problem. Next, coming to complications, two main ones, perforations and nerve reflux. There is this paper published in 2022. They have given a kind of a score depending on the extent of the depth. Except for grade 3, for rest of the doubtful perforations, I think just a prolonged indwelling catheter should not be a problem. Which are the subset of patients where you risk perforation? One, elderly patients because their wall are thin. Over distension because of increased irrigation has to be reduced. And normally what does the literature quote? The incidence of perforation is around 10%, of which 96% of them are simple extraperitoneal, which can be just managed with prolonged indwelling catheter. Once you have extensive extraperitoneal perforation or an intraperitoneal perforation, what do we do? Is there a risk of seeding? Is there an upstaging? The literature is a bit dicey, with some papers saying that seeding is low, whereas others saying that if at all it's a high-grade tumor, there's a good chance that seeding may happen. In which case you go in, try repairing the perforation if it is significant. Otherwise, a prolonged catheterization or a peritoneal drain should be good enough. Next, coming to prevention of obturator jerk, I'm certain all of us at some point would have had a very bad obturator jerk. We would have taken all possible precautions and still you end up having an obturator jerk. That is what it is. We have to live with it. And how do we minimize it? General anesthesia, yes. Spinal with an obturator block would help. Half-filled bladder may help. Using bipolar compared to monopolar would be a helpful thing. This is where the role of laser comes about. Any posterolateral tumor, if you can manage with a laser where you're fearing an obturator jerk, nothing like a laser. And if you're using other energy sources, you can use these short intermittent cuts. But whatever said and done, you have to experience an obturator jerk, only then you'll get more wiser with that. So at the beginning of my slide, I had posed a question and asked you guys to ponder between a T1 high-grade bladder cancer versus a T3B prostate cancer, which one fares poorly? The 5-year cancer-specific survival for a T1 high-grade is around 81%, but a 5-year cancer-specific survival for a T3B, locally advanced prostate cancer, is 91%. Many a times, these simple TURBTs are relegated for the residents, and residents may take it for granted, not all, may, thinking it should be a cakewalk. But then that one procedure determines how you risk stratify your patients. That one procedure determines your further intravesical management and the follow-up. So pay attention, use the checklist so that you get the best results out of your patients. Well, for take-home message, I have 2 French proverbs. Something that has to be done must be well done. So next time when you're doing a TURBT, keep a checklist next to you, do it. Rather than writing a 300-word intraoperative note, draw a nice diagram, highlight it. So the guy next time after 3 months or sometime when he's doing a re-TURBT, he just has to see the diagram, he knows what has happened. And next, performing TURBT is like making love. What do I mean? Take your own time. Don't rush. Spend some time. It is better to be experimented. We have monopolar, we have bipolar, we have laser. There's no end to debate. If you have an opportunity, experiment it, see what suits you better. Control the bleeding. Don't be in a rush. If there's a bleeding, try controlling. Don't panic. Go easy. Control your reflexes. The patient's nerve reflex, I meant to say. Control it. Enjoy the procedure. Don't be in a rush. Enjoy what you're doing. After all, be proud of what you have just done, and you will avoid complications and compromising oncological outcomes. Thank you. May I now invite Dr. Srivatsa for the next part of the discussion.
Can we have a discussion right now?
I would like to invite for chairing the session Dr. Bhalchandra Kashyapi and Dr. Mukunandankar.
Hello, I think better to have some discussion at this time rather than keeping lost. Dr. Ravi, well done. You have given very nice tips and tricks to especially the younger and the beginner. And I have to say only few things. Like you mentioned, giving a pressure at the suprapubic region if the tumor is at the dome. I do not practice this, rather I condemn this because there can be bladder explosion. By doing this, the air gets sucked in when you release the pressure, and there are chances that there may be intravesical explosion and perforation of the bladder. So in this scenario, there are angled loop available. So you should use those angled loop rather than this conventional loop. This is number one. Number two, you mentioned about the radical, extended, TUR, and all those things, end block resection. I would like to say, I don't know how many of you in the crowd are aware of, Dr. Kulabewala from Mumbai was very fond of this particular bladder cancer, was very close to him, and he was doing like a controlled perforation. So what I want to say, everything which is a recent may not be decent, and everything which is decent may not be recent. People have already done it, only we are reinventing the same, their thoughts and technique into our practice. Well, thank you very much.
Thank you.
Sir, can I ask one question, sir, on behalf of Dr. Ramesh? He was asking, is there any role of Trojan section? I personally don't believe that there's a role, but is there any role of Trojan section to see the muscles in the detrusor or not?
Sir, I don't practice frozen section post-TURBT. a couple of limitations that you have to wait for the frozen section and you don't know what you're doing. And that second thing is there are obvious visual cues for us to say that, okay, muzzle has been taken or not. If in doubt, go take another bite of it. That should be
I
okay.
fully agree with that.
So with the permission of chair, just need to add one point. So actually, we were talking about obturator reflux, and so we recently conducted a study just to share some inputs from that. So there is a very beautiful finding where we usually give unilateral obturator blocks. So I think the bilateral obturator blocks primarily is more important than unilateral block. There is a pelvic crosstalk. So there is something came out good that if we do a bilateral obturator block, probably it's helping more as compared to unilateral block.
Thank you, Chairs, and thank you, Ravi. I've been given 5 to 7 minutes. I think my slides are a little longer, so I'm going to cut short it to just give you the conveying. So expanding on what Ravi has said, basically what I'm going to speak about is how to help the TURBT, because the surgical procedure is over and the only procedure that we generally recommend for a non-muscle invasive is a good TURBT, as he rightly said. So I'm not going to go into the risk stratification. Everybody knows that. Only one thing I would like to mention is this. Everybody should be aware of this 2021 EAU NIMBC stratification, where the highest risk or the very high risk has been included, and this is the stratification that we need to follow currently for us to understand what extra therapy that the patient is going to require. Now, we all know that TURBT is in the guidelines as well. Is there any specific reason for that? 17 to 67% of TA and 20 to 71% of T1 has residual tumor. So we have to clear the residual tumor. We have to confirm whether the resection site is completely clear or is there an upstaging in the disease, and obtain any missing elements of clinical information of the extent as well as the prostatic urethra and so forth. So I think we have enough evidence to understand that a re-TURBT of a high-grade tumor is the dictum nowadays. So I think there is no confusion as to whether we need to do a re-TURBT or not. Though there are controversial, trials, RCTs, which doesn't prove sometimes, but again, to us, re-TURBT is a must. Now, is there a difference by doing a re-TURBT? Are you adding any value to your treatment? Yes, a second re-TURBT will increase recurrence-free survival, improve outcome after BCG treatment, and provide prognostic information. Even with patients without muscle, it is said that it is an essential that you do a re-TURBT, and this definitely makes a difference in the end of the day. When do you do it? It's about 2 to 6 weeks post initial resection, and that's what the trial has said. So what can be done to add value to your cystoscopy, your TURBT, and so forth? So I'm going to talk about two things, which is PDD, which is photodynamic diagnosis, and next is the NBI. I think we all know how we do a photodynamic study. We introduce the fluorescent guided, and then you do a TURBT, and then check the veracity of your TURBT by checking that you have cleared all the tumors, the base of the tumor, and so forth. Now, there are a lot of evidences which suggest that PDD definitely help. There are also 2 studies which has not shown that much financial as well as outcome related changes. But this is the comprehensive database study of all the RCTs till date, which has clearly proved, you can see all the pointers are towards PDD guided TURBT, especially in difficult cases. Now, is there any guidelines? Both the EAU as well as the AUA has included in 2024 that a PDD guided or an NBA guided TURBT should be part of your armamentarium. Now, coming to the NBI, I think it's just an optical enhancement. You don't have to inject any fluorescent dye or anything like that. And definitely because of the change in the vascularity of the bladder tumors, you tend to see something that you would probably have missed in a white light cystoscopy. So for the lack of time, I'm just going to show you a small video. I'm going to fast forward it. And you can clearly see the change in the vascularity, the color change, the green and the brown changes when compared to the normal white light cystoscopy. I think this is very, very essential for us to give a good clearance in especially a non-muscle invasive tumor. Right, I'm going to skip all these things. So I think there are a lot of studies, including NBI, to be a part of the cystoscopy as well as the TURBT. Definitely, it leads to a better outcome, as you can see in the trial. So I'm going to skip all this for the lack of time. So this is the final thing I would like to say. 6% reduction in the risk of recurrence, 17% at 1 year and 6% at 3 months, and 18 months at the rate of recurrence. Now, intravesical therapy, there are a few things I would like to mention before I end my talk. I'm going to skip all this because we all know we put an immediate mitomycin C. We have adjuvant therapy with mitomycin or gemcitabine or docetaxel, whichever you follow, and definitely immunotherapy, BCG, as well as chemotherapy. And I'm going to skip all these things. I just want to talk about two new things that has come up. It is the intravesical delivery system, and that is what I want to talk about today because it's something new, especially for the residents. So we have the gemcitabine tablets in what is called as a TAR 200 system. It can be implanted into the bladder, and that is slow release, and it takes care of the the recurrence rate and the progression as well. This was a study that was done. It clearly shows that it was very safe and tolerated very well. The patient did not have much complaint, and the follow-up showed a very good thing. Everything is under trial. It's not yet into the this thing. The second one is what is called as a TAR 210, which had the hertafidinib coming on, and this is how they did the trial. Give me just 5 seconds to finish it off. This was presented in the ESMO 2023, which showed a good efficiency as well as a high recurrence-free rate. In addition to that, the Pivot 006 trial again uses what is called as an oncolytic immunotherapy. Now, this is the introduction of an adenovirus to kill the cancer cells. This also has to be taken into account. These are the various studies that is there. Right, finally, early cystectomy. I think early cystectomy should be a part of the armamentarium, especially in treating very high risk, multiple tumors of, TCC. We all know, and there was a discussion right before the talk, if you do a late cystectomy, you end up doing a...
Dr. Srivatsan, I think the others will talk on this.
Right, sir.
Yeah, thank
I'll
you.
end with that.
It was a very good talk. Any questions? Any role of MRI or PET scan in between the first and the second look?
For non-muscle invasive, no, sir. For muscle invasive, probably yes. And the TRBT itself creates confusion with regards to what exactly is going to read. No, no, sir.
MRI just to know the muscle invasiveness in between the maybe around 6 months, 6 weeks after the...
Yes, sir. We can use the Virat score to analyze whether it's a difference in the outcome. Yeah.
Yeah, we'll have Dr. Arvind Panda. I think he is talking on BCG failure options. Both of you, and Manoj.
I think we need to clarify the time. This is a tandem talk. So total time is 20. 15 plus 5, okay? So please be clear over the time. Thank you.
Good afternoon, everyone. Both of us will be talking about options after BCG failure. And I would like to thank the conference secretariat and the organizers for the opportunity. So the current standard, after this wonderful talk about non-muscle invasive cancer and BCG therapy, we were going into a stage where what happens if BCG fails. The current standard for intermediate and high-risk non-muscle invasive bladder cancer is TURBT followed by intravesical immunotherapy or chemotherapy. That is the standard of care. But the recurrence rate is about 15 to 61%, and it can progress to muscle invasive disease. We know that already, about 15 to 50%, particularly on long-term follow-up. And this thing about initial complete response, almost 70% get an initial response, but if you really follow them after a year, a complete response after a year or after a couple of years, you realize that the BCG failure rate, even after you give induction and maintenance, is about 50%. This is something we know. And here radical therapy is now the definitive treatment. And what is that thing that causes BCG failure? We have certain gene mutations, specific PTEN mutations. They activate PAC1 dependent pathways of micropinocytosis. So the entry of BCG into these cancer cells is dependent on specific mutations apart from the T cell activation. So if these mutations are absent on certain cell lines, you can get BCG failure or a BCG refractory status. So when we talk about, when there is a failure and when there is BCG unresponsiveness, we'll talk about the definitions after this. The standard of care now, I want to make that very clear. The standard of care based on current evidence is radical cystectomy. There is no role of any other therapy as the standard of care. So all other therapies, even what we're going to talk about now, must be considered experimental. And what has been found in a review of a lot of prospective trials, further prospective trials on bladder preservation's protocol, that if there are recurrence that only papillary only, you can just put a scope and see them, And these are more effectively treated with RC rather than if there are CIS containing tumors. So again, CIS containing tumors, we're talking about early cystectomy, and we're talking about other therapies rather than re-challenge with the other experimental therapies we're going to talk about. So I'd just like to get to the definitions. So broadly, any high-grade disease occurring during or after BCG therapy. BCG, this is called BCG failure, and these are patients are unlikely to respond to further BCG therapy. BCG refractory is defined as high-grade recurrence within 3 to 6 months while patient is still on BCG. BCG relapse is recurrence after completion of BCG maintenance despite initial response, should be within 6 to 9 months of the last BCG exposure, and unresponsiveness is all refractory tumors who develop a high-grade T1 or TA high-grade tumor or CIS within 12 months of completion of adequate BCG exposure. And when we talk about adequate BCG dosage, how do we define that? Completion of 5 to 6 doses of an initial induction course plus 2 out of 6 doses of induction course or 2 to 3 doses of maintenance therapy. If this is fulfilled, we see the BCG therapy is adequate. So if you look at the evidence now, the prior intravesical therapy that has no impact on the effect of BCG installation, treatments other than radical cystectomy are experimental, okay? And we have already defined that. I will now invite Dr. Manoj to continue about the standard of care after BCG failure.
So the standard of care after a BCG failure patient is cystectomy only. So there is no intravesical therapy after BCG that has proven to be a more robust or having a more durable response. And so development of this effective or a safe or durable intravesical treatment remains a critical unmet clinical need. So the necessity is the mother of all the inventions. So then the novel therapies and everything came in place now. So right now we are going to discuss about a case which we came across recently. I think everybody will come across this in their practice. 65 years old male, non-diabetic and hypertensive, who is a ECOG1, underwent TURBT, and the post-op HP shows high-grade non-muscle invasive bladder cancer, is involved in the lamina propria only. So discussed in our MDT, and he was explained about the pros and cons and started on intravesical BCG installations. So after 1 year completion of third maintenance, patient had recurrence. So he underwent a TURBT and HP shows T1 high grade, and he was given option of radical cystectomy, not willing, want to try other options. So what next? So in these scenarios, most of us, in the Indian scenarios, we have very limited options. So we get only intravesical chemotherapy as the next line. But there are a lot of other options which are now available, particularly in experimental phases. So there are intravesical and systemic immunotherapy, then the intravesical cytotoxic therapies, oral targeted therapies, intravesical gene, both bacterial and viral therapies, and vaccine. So if you take about intravesical chemo, in this, the number of patients who are there in the trial are very low. And in this particular thing, when they are given cabazitaxel, gemcitabine, and cisplatin, if you take that study, you can see the response rate is really good. Even though the number of patients in that group are 18, but the response rate is very good. And I'm going to talk about this trial in the next slide. So how many are having the drug delivery system? Can you raise your hands? Have you anyone used a chemo hyperthermia or EMDA or any drug delivery system in India? Huh?
That is a very, because we are just asking about post-BCG failure. Has anybody in the audience used any of these chemotherapeutic regimen before moving on to cystectomy? Yeah, we have got some hands. Thank you so much.
So this is a chemo hyperthermia using MMC, where the European phase 3 trial comparing BCG versus chemotherapy with MMC was randomized to 190 patients. And it shows that there is a significant improvement in 24 months RFS when compared to BCG, that is 78 and 64.8. However, no significant difference in if analyzed by intention to treat, but the drawbacks of the study is it is underpowered and there is a slow accrual, so there is early closure of the study, and the maintenance of BCG was given only for 1 year. So sequential BCG plus MMC with the EMDA, it's an electromotive drug administrative system. So it is also a retrospective study given in the installation with this fashion of 2 BCGs with 1 MMC, again 2 BCGs with 1 MMC. So total 6 induction and 1 year maintenance. So very small study, 22 patients were there, median follow-up of 28.8 months. 6 patients had high-grade recurrence. Good response, but we have to select these patients. That's what they recommended in the end of the study. And there's a device-assisted intravesical chemotherapy versus BCG, the systemic review and meta-analysis. 10 studies combined with 1,160 patients. No significant difference were observed between the two groups in terms of progression, overall survival, progression-free survival or disease-free survival. So this patient, after recurrence, he was given choice of having a radical cystectomy, but this patient doesn't want to undergo cystectomy. So we explained about the sequential gemdosi intravesical therapy, and patient opted for that. And so how many, after BCG failure, so what is your go-through therapy? How many are okay for BCG, gemdosi or MMC? Can you raise your hands? So BCG failure patients, what is your next option? Is it gemdosi or MMC? Gemdosi.
How many of you will think about a re-challenge with another induction course of BCG? You have, okay, one, we have 2, 3, 4 hands.
So sequential...
It will depend upon the grade that you are getting. The second...
All are high. All are high. Most of the times we see high.
Your thought process will be different. But
indications for that. That has to be more than 1 year of therapy, and the recurrence should not be high grade.
So coming to the sequential intravesical gemdosi, so this is one study where they are seen in 107 patients, given 6 weeks of induction phase and maintenance for 2 years, and the surveillance done for next 2 years, and which showed a 56% had adverse events, which are compared to BCG is very low, which are all grade 1 and grade 2. And 2 years recurrence-free survival is 82%, which is a little impressive, and 2 years cancer-free specific survival is 100%. So coming to valrubicin and docetaxel, so valrubicin is one of the chemotherapy medicine which is FDA approved in initial phase, in initial 2012s and 13s in the BCG failure patients. Based on this data, where 75 patients with low-grade NMIBC has recurrence-free survival of 73%, whereas in high-grade it is 38% at 2 years. And 56% of the patients had persistent CISs throughout. So even though it has a low response, but that is only available intravesical chemo, and cystectomy-free survival and cancer-specific survival is 84% and 96% respectively. So it is considered as an effective rescue treatment in BCG failure in NMIBC patients. So already TAR-200 was discovered. It's an intravesical delivery system which will help to keep the gemcitabine in a little longer time, that is 21 days. It is a very small coin-shaped delivery system which can be done with cystoscopy, and after 21 days you can remove it by cystoscopy. So they combined TAR-200 with a monoclonal antibody, PD-L1 only, setrilimab. So it is a 3-arm study where they setrilimab alone, TAR-200 alone, and they combined TAR-200 with setrilimab. So total 200 patients which are randomized, and recently they published the interim results of TAR-200 monotherapy arm alone. So 54 patients where the 77% has complete response at the end of 3 months. So the study is going to complete in 2027, which we'll get the data after that. And this is one thing where the triple chemotherapy, which is a platinum-based induction regimen, includes 2 to 3 installation every week, and it's a dose-dependent escalation where the patient is able to tolerate the escalating the dosage of the chemotherapy, which shows the recurrence-free survival is 83 and 64 at the end of 1 and 2 years respectively. And interestingly, patient who received high dose of cabazitaxel or cisplatin, that is out of 10 patients only, the recurrence-free survival is seen 183 in 1 and 2 years, which is pretty impressive. So this patient, after taking 6 weeks of induction of gemdosi and monthly maintenance, after completing 6 months of maintenance, he had recurrence again. And the TURBT done, which was T1 high grade. So again, we suggested radical cystectomy. Patient is not willing. What next? So can I ask the expert panel and the audience, have you used any immunotherapy in these scenarios or any novel agents? Because when I'm going through the data or the studies, it is very, I'm not able to see whether these drugs are available in India or not. So I just want to ask, because it's the biggest oncology group here sitting here, has any experience of using any immunotherapy in BCG failure patients?
So we are talking of intravesical immunotherapy and we are talking of systemic immunotherapy. How many, can we have a show of hands please? Anybody has used it for BCG failure? Systemic immunotherapy, sir, also you've used. So 2, 3.
So basically immunotherapy drugs, what we commonly use, what we know is pembrolizumab. The other drugs, what are coming up is enfortumab vedotin, which is FDA approved in metastatic CA bladder setting. and sasanlimab and jalifrelimab.
So what the clinical evidence is about this is that IV pembrolizumab induction with installation of BCG, that is the one which had a complete initial response of 78%. But if you look at the long-term follow-up, that is lacking. And the other one, MCNA, is actually a specific derivative of Mycobacterium bacilli. Only the cell wall which is instilled, that didn't have much good response. So we're only looking at pembro, either IV pembro alone, which doesn't have a great response, less than 40%. But if you give IV pembro plus induction with BCG, that has a far better response. Again, but we're not sure about what will be the response rate after a year.
So I'll be talking about this in the Keynote 57 trial, which gave the pembrolizumab FDA approval in this setting. So it has 101 patients followed for 3 years, and 96 patients were included in the final analysis. In those patients, 41% had clinical response at 3 months follow-up, and sustained response lasting 1 year is only in 20% of the patients. So patients who have taken this pembrolizumab, only 20% had a complete response at the end of 1 year. So still, this is given FDA approval. So what sir is saying, combination with intravesical BCG, that is Keynote 676, which is expected to finish at the end of 2024, will give a better results, hopefully. So intravesical pembrolizumab, so that is also seen in this one phase 1 trial where 9 patients were given 67% recurrence-free rate at 6 months, which showed a CD4 T cell increased, elevated in urine after treatment. Very grade 1 and 2 adverse events only, but 1 patient expired due to myasthenia gravis, which they related to the treatment. It's an enfortumab vedotin. This is also not in given intravesically, which is available in India. The studies are going on. Sasanlimab and jalifrelimab, it's CRUST trial, which is given subcutaneously. 300 milligrams were given every 4 weeks. And jalifrelimab is also CTLA-4 monoclonal antibody, which is also in phase 1 trial. Both are not available in India at present. Durvalumab, it's called Durance trial, where they combine durvalumab with a 5-peptide cancer vaccine. And there are durvalumab monotherapy trials also. It is available in India, but mainly used in cholangiocarcinoma. It is not FDA approved for bladder cancer at present. Coming to viral and bacterial-based therapy, so in this, the main thing what we want to highlight is nadopharyngeal firadenovac. So it is an adenovirus vector combined with human interferon alpha-2b gene. So basically, when the BCG therapy started, there is a long hope for this human interferon alpha-2b gene, but it is not giving a durable response because of the exposure. So when they combine with this adenovirus vector, which is able to deliver this interferon alpha-2b gene in the bladder urothelium, it is staying in much, it's in the longer time. So it's a phase 3 trial where 157 patients who are having repeated doses are given at 3, 6 and 9 months. Patients with CIS, the CR rate is at 3 months was 53%. Almost half of the patient remained free of disease at 1 year. And patients without carcinoma in situ, 73% disease free at 3 months. And 60% continue to be free at 1 year. Progression to MIBC occurred in 5% and 6% of patients with and without CIS. And grade 3 and 4 adverse events are seen in 18% of the patients. So based on all this data, the FDA given approval in 2022 for this drug. The other one is TARA-002, intravesical preparation of Streptococcus pyogenes group A drug, which is a lyophilized benzoylpenicillin by
You'll have to wrap up, please.
Yeah. So it activates both innate and adaptive immune system. Currently, it is in recruiting phase, completed in anticipated study completion 2026. Pseudomonas aeruginosa given intravesically by a small injection during the procedure and after the intravesical saline infusions were given. And CG0070, oncolytic recombinant adenovirus, it causes a local expression of granulocytic colony stimulating factor, which helps in anti-tumor property through cell death and lysis. It is combined with systemic pembro also. It has a good response initially. And there is a non-viral therapy where a nanoparticle formulation of nucleic acid is given into the bladder epithelium. The interim result shows a CR rate of 67% among those who complete 1 cycle of EG70.
I think you can move to the conclusion slide.
Yeah. So the take-home message is radical cystectomy is the standard of care at present. GEM-DOSI and MMC with assisted drug delivery system can be a second option for patients who are unfit or not willing for radical cystectomy. And intravesical platinum-based chemotherapy, which we described, the triple therapy, shows a promising preliminary data, but it needs to be evaluated more with a robust. Then systemic pembro may not be feasible in Indian scenario because very expensive, but only 20% of the patient will have complete response at 1 year. So we need to weigh the balance. And adenovirus vector with human interferon alpha 2b gene seems to be a viable option alternative to at present for all these BCG failure patients.
If we have some time for questions.
So the most important message here is all the data we have, whatever trials we have, they are small numbers. We really don't have very large numbers, and most of the data are some phase 2 and phase 3 trials. It's only the next 2-3 years that we're going to get more data on this, and we're going to get some sort of really robust message.
Yeah.
So probably bladder cancer is where prostate cancer was about a decade back. So can we have any
before
questions?
we open I just have a small question for you. So there are a lot of patients who cannot tolerate BCG. They have rather than BCG toxicity, minor or major, whatever. Where do you place them? Do you call them BCG failures, or where do you place them in your management?
They are not classically failures. They just don't tolerate BCG. So these are patients who would do well with this intravesical chemotherapy, because these are actually, if you look at all the data, the patients who had bladder cancer high grade with CIS, these are the patients who do the worst. So those patients may not fit into this criteria. So it is still worth trying for some sort of bladder preserving protocol with intravesical chemotherapy with them. Only if they fail or progress, you can go. And what we need to remember is the patients who had progression despite this therapy to muscle invasive, they have a far worse prognosis than patients who were T2 initially.
Yeah, patients who do not tolerate, can we go in for some other this thing like valrubicin or gentamicin?
Yes, absolutely, you can go in. Absolutely, that's what I said.
And there are a lot of trials coming in BCG naive setting also, sir, where immunotherapy and everything is given in BCG naive people also. Probably that has given us a data where we can avoid BCG in the near future.
Any role of any tumor marker to predict that this patient will be BCG non-responsive?
I don't think that has been standardized as of now. No.
Yeah,
we have tumor markers, but just for recurrence, to predictive models, we don't have as of now.
And has the
including tests like FISH test, Eurovision, and all will not.
All of them show that there is going to be a recurrence, or there is a recurrence even before cystoscopy shows that. But I don't think they are predictive. They don't have predictive value.
And even the dose and the strain, has it been categorized?
Yeah, that is a very interesting question, those slides. What we have in India now, what I want to tell you is the Moscow strain. We are not getting the original BCG, and this Moscow strain, it is only my observation and some of the people I have spoken to, have resulted in a far higher rate of BCG related complications rather than the original strain which we had. Yeah,
Right.
so I think most of us have that situation.
I think we have a couple of minutes. We go to the OR before we move to the next. Thank you very much. Thanks.
Babu, we're coming live. Okay, can we talk to Dr. Anup, please?
Anup sir? Anup sir? Your mic on,
For the
sir.
attention of the audience.
1 minute,
there will
1
be
minute, Dr. Anup. Yes, sir.
For the attention of the audience, we will not have a lunch break. Lunch has started. I think most of them have waited. It's vegetarian food. Disappointment to me. But for most people, it's very entertaining. So please have it. We are not going to have a break.
Yes, Dr. Anup, you're on.
Yeah, meanwhile, can we have next speakers, Dr. Rajesh Reddy and Dr. Ghaus here, please?
Fantastic, Anup. Can we move to
Anup,
operation theater?
Sorry, there's a question.
Before, Anup, I just have a small question. Do you prefer staplers, or why not the other energy sources to take down these pedicles? I mean, there are wonderful energy. I meant vessel sealers. If there are different vessel sealers, do you have any idea about, better than, okay. Okay, can we move to the next one?
Yes, sir. Shrenik, sir,
Yeah.
your mic on, sir.
Okay. So I think I don't know if you have noticed, definitely probably laparoscopy as an age, because there were so many extra vasculature which was there on the upper pole, lateral you will see. All these veins probably you can see better magnified under the laparoscopy. Probably that is, I'll just show you. I don't know, have you noticed? This is a completely the lateral surface, the upper here you will see a lot of big veins were there. So everything was done under vision. The only part which is remaining, which we will just clear out. But again, as I say, look, these are the bigger veins which were there. So probably it's an individual preference, but in laparoscopy you can better see the things and can take care of it. So we have put a lot of clips everywhere, and anyway, once again, I hope this is clean from upper pole, hilum, everywhere. Show them the hilum. What is the advantage is, this is completely, even though this is this big mass with so much extra vascularity, you can see the hilum. Everything is over there. Yeah, we might have put little more clips, but depending on the vasculature, this is a completely clean. This is a psoas. So this is the best part. And I believe now we are only left out with the ureter and the gonadal that we will take care. So once again, thank you very much, Uro-Onco, for given opportunity. Thank you.
Thank you so much for demonstrating a fantastic laparoscopic radical nephrectomy. I think now we can move to next talk.
Thank you,
Dr.
sir.
Rajesh and Dr.
We'll
Sayed.
continue to watch you, sir.
Yeah.
Dr. Gosiara.
Yeah, good afternoon, respected delegates. At the outset, I would like to thank the Uro-Onco section for giving us this opportunity. I am Dr. Gauss, and my colleague Dr. Rajesh are going to speak about the radical nephroureterectomy and the special aspects, how a radical nephroureterectomy is different, and what are the conundrums in it. Our objective here is to briefly discuss about the preoperative issues, the surgical approaches, bladder cuff management in a radical nephroureterectomy, the template lymph node dissection, the timing of an intravesical mitomycin, and other special situations which are specific to a radical nephroureterectomy. Coming to the first one of our preoperative issues, can I have a hand raise here as to what we do in situations when you have got a clear-cut imaging where we see a centrally placed enhancing lesions in the renal pelvis, and on endoscopy, this is the image that we see. How many of us go ahead and do a biopsy of this, and how many of us directly go for a nephroureterectomy? For a biopsy? People who would wish to do straight away a radical nephroureterectomy? Thank you, sir. Yes, sir. So what does the data say? Data says that a URS alone, a diagnostic URS alone, does not increase the recurrence or doesn't spread the tumor, whereas if you do a biopsy, it definitely increases the chances of a local recurrence and a dissemination also. Even the guidelines say just cytology is not enough and you need to do a diagnostic ureteroscopy, but rather do not do a biopsy. So when do we do a biopsy even though we see a lesion on imaging? So these are the three situations. Whenever there is an indeterminate thing on a imaging itself, you are not sure whether it's a papillary lesion, then you do a biopsy. When you plan to do a kidney sparing surgery, you are doing it in a solitary kidney and you need to do a partial nephrectomy or a kidney sparing surgery, that is when you do a biopsy also. In a setting where you plan to give a neoadjuvant chemotherapy, even then you need a biopsy whether you need to give a neoadjuvant or go ahead without that. So coming to the different steps of a radical nephroureterectomy, again we have broken down into surgical access, nephroureterectomy part, bladder cuff excision part, and the lymph node dissection part. Coming to the first one, access can be even an open, laparoscopic or robotic, but one has to adhere to the strict oncological principles whenever we are doing either of these procedures. And invasive and large tumors, it's always better to do an open access. If it is an open access, one can go with a midline incision and do a nephroureterectomy, One can have a separate incision for the flank part where you do the radical nephrectomy part, and for the bladder cuff part you can have a separate incision in the lower abdomen, or you can have a flank incision extending down onto the lower abdomen altogether. When coming to a robotic approach, we follow this different techniques, wherein the traditional is doing the nephrectomy part in a flank position, and the bladder cuff part again changing the position into a Hedlow-Tredelenburg position and do the bladder cuff part, if it is a robotic procedure. What we describe or what we regularly follow is this port swapping technique, wherein I'll be describing it, or what is routinely followed in the Western world is a oblique port placement. This is traditionally how a laparoscopic, a robotic port placement is done for any radical nephrectomy. You have an additional two assistant ports which are used for swapping the left working port in this situation. And once you have done the nephrectomy part, at 15 to 20 degrees head low position is given, and this is how you have a view of the pelvis with all the bowel sliding onto the upper quadrant of the abdomen. The caudal assistant port is now used to swap with the caudal robotic port. So this can be done by intussusception of this robotic port into the caudal assistant port without putting any additional port for doing the bladder cuff. So this is how it looks while you tackle the lower part after a nephrectomy is done. Coming to doing a nephroureterectomy per se, again a few principles here. You clamp the renal artery first, then go back to the ureter, clip it, then come back and divide the renal artery and the vein. This is to prevent a seedling once you have done with the renal artery. So that is the division of the renal artery and vein, and rest of the part going beyond the girotas fascia all around to mobilize the kidney and to finish up the nephrectomy part of a nephroureterectomy. Coming to the bladder cuff excision, again it can be an open or transurethral resection and a pure laparoscopic or a robotic bladder cuff excision. In open techniques, the regularly defined techniques are the transvesical or extravesical techniques, but this technique of pluck and intussusception have to be abandoned, and they have a potential risk of a locoregional recurrence. Coming to the robotic bladder cuff excision, it starts with mobilization of the pelvic part of the ureter after you have done the port swapping. That is the ureter being dissected down into the pelvis till you reach the bladder. And we give a longitudinal incision along the long axis of the ureter onto the bladder. One has to be careful that the bladder has to be completely emptied before we do the cystotomy. You identify the ureteric orifice, and seeing under direct vision, you give a scoring incision all around this ureteric orifice, full thickness involving the bladder cuff and the muzzle, so that you take care of the lymphatics as well as the mucosa. Here in this case, this being a female, you can do a uterine sparing bladder cuff excision also, so that you can deliver the ureter once you have scored it all around in the bladder and deliver it below the uterine artery without even dividing the uterine artery. The same thing can be followed for a vas deferens. We all know that water flows under the bridge, and you can preserve these two structures whenever we want to do this. So once the ureteric cuff is taken, the bladder closure is done from below upwards, taking care not to involve the ureteric orifice on the other side. You put a prophylactic ureteric catheter on the contralateral side. Also, one has to take care not to rupture the Foley's bulb, and you can partly empty the Foley's bulb before you complete the suture onto the bladder. So that completes the bladder cuff excision. The specimen has to be immediately bagged and exteriorized to prevent intraperitoneal seedling again. What happens if you inadequately excise the bladder cuff? This patient presented with a huge bulge just below the ureteric orifice and had to undergo a TURBT. And once you incise, there was no intravesical projection of the papillary lesion, but once you incise the area, you can see that a tumor is spouting out of this ureteric orifice. Because the recurrence, if you don't do a bladder cuff excision, is up to 70%, that is the rationale of doing a bladder cuff excision. So coming to the lymph nodal dissection and further special scenarios in a nephroureterectomy, my colleague Dr. Rajesh will take care.
the lymph node dissection for radical nephroureterectomy. Initially, Weber Kondo et al. Described the lymphatic drainage depends on the size, site and side of the ureteric lesion. These are the different templates for lymph node dissection. So the same authors have studied whether the complete or incomplete and low lymph node dissection, does it have any bearing on the oncological outcomes? It is proven beyond the doubt that complete lymph node dissection has got a better edge, and the oncological outcome is better if the tumor lymph node dissection is done for higher stages. So there are a few fast facts of lymph node dissection during radical nephroureterectomy. The completeness of the template-based lymph node dissection has a greater impact on the survival than the number of nodes removed. And the higher the stage of the disease, more pronounced the advantage of template lymph node dissection. And the lymph node dissection appears to be unnecessary in case of low-risk disease. However, the tumor staging is inaccurate in preoperatively. So this is a case of left mid-ureteric tumor where we performed the template lymph node dissection bearing the aorta and para-aortic area, pre-aortic area completely all the way from the hilum to the bifurcation of the aorta. Coming to another interesting topic, intravesical mitomycin. We all know that rate of bladder recurrence is more after radical nephroureterectomy. It is around 22 to 47% if nothing is given. And there was a trial, ADMIT-C trial, where intravesical mitomycin was given, and it was proven that it prevented the bladder recurrences. But this is a case where we did radical nephroureterectomy for distal ureteric tumor, and post-operatively we can see the tumor tissue in the Foley's catheter. And it is very evident, and post-operatively patient, within 6 weeks, patient presented with hematuria, and we can see the multiple papillary lesions in the bladder. So what is the optimal timing of intravesical therapy? The traditional orthodox approach is pre-installation cystogram and single post-operative dose of intravesical mitomycin 2 to 10 days after surgery. But current trend is different. Currently, most of the institutions are giving intraoperative installation of the mitomycin into the bladder, and thus there is evidence. So, intravesical mitomycin, which was given intraoperatively and postoperatively, when compared with the postoperative intravesical mitomycin, the bladder recurrences was minimized when intraoperative mitomycin was given. The estimated probability of 1 year bladder recurrence rates were 16% versus 33% for intraoperative versus postoperative mitomycin C. So it is very clear, intraoperative mitomycin has got it prevents bladder recurrences effectively. So this is what the protocol we follow in our institution. So intraoperative mitomycin for renal pelvis, upper ureteric tumor, instill mitomycin immediately after catheterization before surgery. Clip the distal ureter once the renal artery is divided. Drain the bladder and irrigate it with 100 ml of normal saline before the bladder cuff excision. For distal ureteric tumors where we cannot clip the ureter distally, they perform the leak test after the closure of bladder rent after bladder cuff excision and instill mitomycin immediately. And dwelling time is around 1 hour. So these are a few special circumstances where radical nephroureterectomy was performed. This is the case of the grossly locally advanced distal ureteric tumor, where we have given neoadjuvant chemotherapy. So the neoadjuvant chemotherapy for upper tract urothelial carcinoma, this is relatively sensitive to chemotherapy. It is already proven the evidence in bladder cancer, and it may eradicate some micrometastasis, and it results in pathological downstaging and better renal function and cisplatin eligibility before surgery rather than giving chemotherapy after surgery. The oncological outcomes, yes, multiple meta-analytic studies showed that there is an oncological benefit of giving neoadjuvant chemotherapy, but there is no level 1 evidence for it. The disadvantages are the potential risk of overtreatment without accurate pathological diagnosis.
Can we have a hand raise here for how many would do a neoadjuvant chemotherapy for a locally advanced on imaging itself for a lower ureteric tumor, rather, or do an adjuvant after a nephroureterectomy or a TURBT is done? for chemotherapy, neoadjuvant chemotherapy, and for adjuvant chemotherapy, equally both. More for an adjuvant.
Yeah. And for adjuvant chemotherapy, it is a POW trial where adjuvant chemotherapy is given for T2 to T4 diseases and node positive disease. The post-operative gemcitabine and cisplatin was given. And the primary endpoint was disease-free survival. So we can see the disease-free survival is far better when patients received adjuvant chemotherapy for locally advanced disease. This is another interesting case. The patient presented with hematuria. Preoperative imaging did not show that much locally advanced disease. There is a tumor in the left renal pelvis going into the ureter and involving the parenchyma. The open nephroureterectomy was planned. Inside there is a gross locally advanced disease, extraureteric extension, and it is fixed to the psoas muscle and the hilar structures as well as the aorta. So it was not a complete R0 resection, it is in fact R2 resection. Immediately we placed metallic clips where the positive surgical margins were there, and the patient was sent for adjuvant chemo RT. Here we can see the chemo radiotherapy template for the positive surgical margin.
Once again, public poll as to how many would say it would be an inoperable case and shut it off, or do a whatever wide local excision is possible and then plan for a metal clip, wide local excision. Right, perfect, thank you.
But wide local excision was not possible for that case. It is completely grossly fixed. Yeah. So there is evidence for adjuvant radiotherapy for upper tract urothelial carcinoma for a grossly locally advanced disease. Yes, the local regional recurrence was decreased, but however, overall survival was not deferred. So another thing is post-radical nephrectomy histological surprise. A 50 years male evaluated for painless hematuria elsewhere and CECT reported as a right renal mass underwent radical nephrectomy. Surprisingly, histopathology is high-grade urothelial carcinoma involving the renal parenchyma. So whether to go for distal positive, there was no, the distal ureteric stump was clear. So whether to go for distal ureteric stump excision versus surveillance.
Surveillance? Excision of the distal ureteric stump.
This case excised, but if he is around 70-year-old.
Sir, mic please.
He was indeed 75.
I think we should not debate on this issue because I have attended 2 medical legal cases in same scenario where the surgeon has not excised the distal ureter, and court goes, what are the guidelines? They see the American guideline, European guideline, bring those guidelines, and you have to follow those guidelines. If you're not followed, then probably you will be in a problem.
Sir, please enlighten us. If you have we don't have a biopsy. On imaging, it appears to be a renal parenchymal tumor. You do it as if it's a renal cell carcinoma. Okay. You do a radical nephrectomy, and then a biopsy comes it as a TCC.
No, then you are supposed to go in and remove that ureter along with the
contention. That is the contention. We need to do a ureterectomy after we get a biopsy
yes,
of a TCC.
My only contention is we always call this bladder cuff, always. This is a synonymous going on for many decades because that time we could not pour the ureter. We have to take a part of the bladder along with the ureter. But if you are very good now, these days robotic, like you are doing a ureteric reimplant, you first take out the ureter, then you reimplant the ureter, you go right intravasically. So there is no need to take the cuff of the bladder in those cases like you are mentioning, upper ureteric tumor or kidney TCC. So you have to core the ureter right up to the intravesical part, taking the perimetal mucosa along with. Thank you very much. I think very exciting talk and very nice, and they have given some insight into this a very difficult subject. Thank you very much.
Thank you.
I'll invite Dr. Ganesh Bakshi and Dr. Saurabh Patil for the next talk.
Sir, we just need to go to the theater for 1 minute. Dr. Shrenik just wanted to tell us something.
Yeah, okay, you could move.
Yeah.
Go theater to zoom on. Yeah, Dr. Shrenik, you're on.
Yeah, if you can appreciate, there were a lot of collaterals, but it is completely done. This is a clean psoas, and shows the hilum is okay, and this is a lower pole. The complete psoas from the up to pelvis, ureter and gonadal has been taken care. All right, thank you. I just wanted to show the fossa. Yeah, thank you, thank you.
Yeah, thank you, Shrenik.
Yeah, yeah.
We'll move on to the talk. Can you switch back to the hall, please? Yeah, over to you, Ganesh and Saurabh.
Thank you, everybody. Thank you, Chairperson. I mean, this is not a topic.
This is a very nice recent concept of Dr. Vashi, tandem talks, very nice.
Bladder preservation, P2. 16, yeah.
16. So, we both are discussing the topic bladder preservation versus radical cystectomy in T2 MIBC. I am at PD Hinduja Hospital, Mumbai. Saurabh Patil is at Fortis Hospital, Mumbai. And this is not a debate. We are having a debate on this topic for a real long time, maybe last 4 or 5 years. We have heard debates in many programs. So most guidelines, including EAU, give a grade A recommendation for treating MIBC T2, T4A, N0, M0, and also high risk NMIBC with radical cystectomy. It does accomplish a paramount target in bladder cancer treatment and achieves very good oncologic control with acceptable morbidity. Around the world, it is the standard of treatment for patients with MIBC. The relapse-free survival rates are quite good at 5 and 10 years, as seen 62 to 68 and 50 to 66%. And a big series by Hotman with radical cystectomy showed a 10-year cancer-specific survival rates of 67%. But patients do come with this question to all of us. Is there some other treatment, or can I save the bladder in spite of radical cystectomy being the gold standard, so-called? We are not talking about the diversion at all right now. Patients would be like refusing to get out with the bladder, and some cohort is unfit with respect to surgery, anesthesia, or both. Looking at the evolution of bladder preservation, so it was tried in many possible ways. Only TURBT, maximal, only plus RT, TURBT plus chemo, and the more successful is the tri-modality, which has maximal TURBT and chemo radiation. Another success, slightly, which has been published is the tri-modality plus partial cystectomy, and this actually came through with the thought that TMT patients, it was seen that in TMT patients, 10% had residual tumor, 2% had lymph node metastasis, it might be 2 to 5% in actuality. And yet the technique was very good. This suggested that consolidation surgery might have a role along with that. So I would like to ask Dr. Saurabh, we have two options. So how would you take, what is your take on the oncological efficacy?
Okay, so this is the most important question and at the same time most difficult question to answer, because unfortunately we don't have level 1 evidence for this. We have what the RCT which was tried had to stop because of limited difficulty in accrual, so we don't have level 1 evidence, but we do have some good literature. This is a recently published systemic meta-analysis where authors included good number of articles with propensity scoring matching, and what they found was a short-term survival outcomes were comparable in both the groups, but after 5 to 10 years, RC overscores and has higher overall survival rates compared to TMT group. Same happens with cancer survival rate. So initially for 1 or 2 years, TMT is better, but for long-term results, RC scores better. So authors concluded that RC, radical cystectomy, should be chosen over TMT unless patient is not fit for the surgery or patient is strongly desired for the sparing of the bladder. This is another meta-analysis with the same results that initial phase for maybe short-term or mid-term, 5 years, results are better or comparable with TMT and radical cystectomy. But as we move forward after 10 years, radical cystectomy definitely scores over TMT. Like Sir said, tetramodal therapy, when we include partial cystectomy and